Hi, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine. And I'm back with another interesting brain imaging case of the day. As always, I'd like to start out by stating that all of the content found as part of this presentation has been completely de-identified in order to protect patient privacy. So the history in this case is a patient who came in for the evaluation of memory impairment, and specifically, this patient had had progressive language issues and difficulty in naming objects, or if shown an object, difficult time in remembering exactly what the object was for, what the purpose or function of the object was. So this was not an elderly patient per se, but someone who was, I believe, probably in their late 50s, maybe early 60s, just to give you sort of a ballpark age range in this patient. So I have three images for you to take a look at. The image on the left is an axial noncontrast CT. The image in the middle is an axial fat-saturated FLAIR image. And the image on the right is a coronal FLAIR fat-saturated image. So take a look at these images. Keep in mind that history that I gave you and try to figure out what you think is going on here. Okay, so what are the findings? And what's the most likely diagnosis here? Okay, so let's take a look at the imaging. First up, we have our axial noncontrast CT. And as the yellow arrows note in this patient, we have markedly disproportionate atrophy involving the temporal lobes. Now, based upon this image and the FLAIR image that you'll see in just a moment, it looks like this is worse on the left than the right. Both sides are involved, but the left more so than the right. And if you look at where this is affecting the temporal lobes, it's the anterior temporal pole. Very much anterior, maybe even inferiorly as well within the temporal lobes are affected most significantly with this volume loss. So as we look at our axial FLAIR imaging, we can see that there's so much volume loss that the gyri have become very, very narrowed. These are often referred to as knife-like gyri. They're very, very sharp in appearance because you've lost so much cortical and subcortical volume in these cases. And then the coronal FLAIR image, again, showing us that it's disproportionate left greater than right temporal atrophy, and just giving you an overall sense of just how much anterior temporal lobe atrophy we're dealing with here. So, put that all together, the clinical history, again, memory impairment, difficulty naming objects, difficulty eliciting the function of objects when asked by the neuropsychologist. What's the diagnosis in this case? So this is a patient with semantic variant primary progressive aphasia. Now, primary progressive aphasia is a clinical subtype of frontotemporal lobar degeneration in which language is a predominant feature. These patients may have impairment in language use, impaired speech production, or even repetition issues. And that can be further divided into three discrete subtypes of primary progressive aphasia. And those include semantic, logopenic, and non-fluent or agrammatic variants. So this tends to have a bit of a younger onset than Alzheimer's dementia. These patients may present in their 40s through 60s, probably usually a little bit on the older range in their 50s and 60s, but oftentimes it's earlier than we typically associate with Alzheimer's dementia. One of the things I've stressed in a prior case of the day is that the laterality and the location of this lobar atrophy is important. Those are really critical discriminators in trying to tease out which type of dementia the patients have. So in patients with primary progressive aphasia, they tend to have a left predominant frontotemporal atrophy. If you have the behavioral variant of frontotemporal lobar degeneration, not always, but oftentimes they may have more volume loss on the right. That's not a perfect paradigm, of course. Patients with behavioral variants certainly can have disproportionate left-sided frontotemporal atrophy as well. But in general, most people are language predominant, so you can remember it. I'm sorry, most people are left-sided language predominant, so perhaps you can remember it that way. Maybe there's an association between those as well. But these folks, again, tend to have left frontotemporal atrophy is the predominant feature. Now, within that, patients with semantic variant primary progressive aphasia tend to have left anterior temporal lobe atrophy. So this anterior temporal pole has cortical and subcortical volume loss. Patients with the non-fluent or agrammatic variants oftentimes have perisylvian and more frontal atrophy. And then patients with the logopenic variant have left posterior temporal atrophy. And each of these three has a different clinical presentation. So we'll talk perhaps more about those in future cases of the day. But in this case, clinically it fits, and also we can see there's this very marked left anterior temporal lobe atrophy, very typical of semantic variant primary progressive aphasia. So this was a nice paper that was published just a couple years ago in AJNR, and this is looking at visual assessment to differentiate the different types of primary progressive aphasia. We like to talk a lot about sexy tools like voxel-based morphometry, but can you use just your eyeballs, your two eyeballs, or maybe even one eyeball, I don't know, but can you use your eyes alone to try to tease it out? And as it turns out, semantic variant, you probably can. This is one that you can pick up oftentimes when we're looking for areas of volume loss. It can be very challenging to isolate them, especially if there's a background of some cerebral volume loss at baseline. The human eye is not great at detecting cortical atrophy. Well, this is one time in which the human eye may be sufficient, which is in the diagnosis of primary progressive aphasia. So a nice article, nice paper to take a look at, which details a little bit more about the regional atrophy that you see with this particular type of disorder, as well as the other subtypes of primary progressive aphasia. Okay, so let's wrap this up. This was a patient with semantic variant primary progressive aphasia. And the key features to keep in mind that whether you're looking at MRI or CT, you will see frontotemporal atrophy with disproportionate anterior temporal lobe volume loss. Typically, this will be left predominant. There's certainly an increased role in voxel-based morphometry with MRI. We'll show some cases of that perhaps in the future. And if you're doing nuclear medicine imaging, you'll see that FDG PET is sometimes used to evaluate for this particular type of dementia. And in that case, you'll see FDG hypometabolism corresponding to and perhaps even preceding those areas of left anterior temporal lobe volume loss. Some pitfalls to keep in mind. Again, I've said this before in past case of the day, but laterality and location of the lobar atrophy are very, very important. But I do want to stress that they are imperfect discriminators when you're diagnosing these dementias. So just keep that in mind. The imaging alone is oftentimes not sufficient to make the correct diagnosis. So you need to really dig into these patients' charts, look at the medical records, figure out the clinical history component, because that will really add additional specificity, and you can put it together with your imaging findings and hopefully get to the right diagnosis in these cases. Well, as always, thanks for tuning in to IU Radiology Case of the Day. You can follow along on Twitter at NAKuntz, and I would invite you to check out the complete collection of IU Radiology Case of the Day materials, which can be found at radtf.iuhealth.org/COTD. Thanks so much.